Hello and welcome everyone to today's webinar. My name is Sikirtha Tharmalingam, Manager of Evaluation Methods here at Canada Health InfoWay, and it's a pleasure to connect with all of you today to share some exciting work my colleagues in the Performance Analytics team have been undertaking in trying to understand Canadians' experience with accessing care throughout the pandemic. Next slide, Waldo. So we have a packed agenda with lots of interesting findings that we want to dive into. The one note I will make is that you can submit your questions using the Q&A feature found in the Zoom toolbar at any point during the webinar. I'll moderate those questions at the end of the webinar. Next slide. So jumping into our first agenda item of welcomes and introductions, a big welcome to all of you that have joined, new and returning attendees. Briefly, for new attendees, InfoWay's B Collaboration Network brings together jurisdictional leaders, evaluators, and researchers to share best practices, results, and other insights focused on evaluation in digital health. We have regular webinars such as this one to share each other's work. Being part of the webinar of the network, you'll also receive updates on noteworthy evaluation-related activities that are on our radar. And you can contact me to get on our mailing list if you're not already on. And additionally, you can find today's presentation materials and other updates on our website. Next slide. Now I'm just with the slide before. I'm very excited to introduce you to our presenters who are on the line today and who I have the privilege of working with every day. And some of you might have also had the pleasure of working with them. So first up, you'll hear from Waldo Beausejour. Waldo is an analyst with the Performance Analytics team at Canada Health InfoWay. Waldo holds a master's degree in applied economics. He has experience in applied social research and quantitative research methods for over 10 years. He has led and contributed to several quantitative surveys, research, and impact evaluations aiming at investigating the impact of government-led or funded interventions on health outcomes. And then you'll hear from Bobby Gurgu. Bobby is the Director of Analytics here at Canada Health InfoWay and has 20 years of experience across the acute care, government, and policy sectors of the healthcare system. In his current role, he uses data analytics and the development and monitoring of performance indicators to stimulate adoption and demonstrate tangible benefits of investments in digital health. Bobby holds a Master's of Health Sciences in Health Policy Management and Evaluation from the University of Toronto. And then you'll hear from Ellie Yu, who's a Senior Analyst with Canada Health InfoWay, where she drives business decisions using data analytics and business intelligence to demonstrate the adoption and benefits of investments in digital health. Ellie has a PhD in health policy from McMaster University. And we'll go to the next slide and I'll turn it over to Waldo to kick things off.
Thank you, Sikirtha. So let me start to say something. First of all, let's say that anecdotally, one of the questions that Canadians ask at the very beginning of the pandemic was not about banking or shopping, even education. Instead, they were wondering, how am I going to seek out care for myself and my family in the middle of this health crisis without being exposed to the pandemic? And answering this question has led us to collect information on Canadians' health experience during COVID-19. And we relied on a representative sample of 1,500 Canadian adults across provinces and territories that we surveyed using an online questionnaire on a weekly basis from April to June 2020. And then starting from January 2021, we shifted to biweekly data collection. So what I'm about to present now is the uptake of virtual care during COVID-19. So on this slide, on the left, we have the share of virtual visits in total health encounters. And on the right, we have the distribution of these virtual visits by modality, by virtual modalities. So from January to April 2021, all patient reported visits were, 38% of all patient reported visits were conducted virtually, which is, let's say, greater than what we observed during the pre-pandemic period. And phone consults made up the bulk of these virtual visits with 78%. And then video conferencing and secure messaging combined represented the remaining 22%. Now, when we collected information or when we collected data on the interaction with the healthcare system, we discriminated between routine visit and COVID-19 related visit. So this graph, this line graph, shows the trend in modality of the visits for routine visits. And the dotted blue line represents in-person visits, and the green lines represent virtual visits. So let's concentrate on the darker green, which is the total virtual visits. So at the onset of the pandemic, 57% of routine visits were conducted virtually. And 2 months later, virtual visits, let's say in-person visits picked up and then continued to increase while virtual visit seemed to lose momentum. But starting from January 2021, virtual visits for routine visits hovered, let's say, around 40%. Now, when we move to COVID-19 related visits, it is almost the same picture. So we have an increase at the very beginning of the pandemic, and here I'm looking at the darker green line, right? So we had an increase at the very beginning, and in the middle of the crisis, when let's say restrictions were relaxed, we had a decline in virtual visits. And then between January 2021 and April 2021, virtual visits for COVID-19 related visits lied between, let's say, 30%, 28% more specifically, and 40%. We also looked at the distribution of the modality of the visits, let's say, cross type of provider seen. And the idea is to get a sense of which provider was more likely to deliver care virtually. And then on this bar chart, the red parts represent virtual modalities. And then on the right, the data column that you see on the right represents, let's say, virtualization rate in 2020. And this is just for comparison purposes. Now, the gist in here is that private vendor showed a higher virtualization rate, which was 74% in 2020, and now it stands at 76%. And it is followed by regular family doctor with a 52% virtualization rate in 2021. Now, as you have seen, Canadians are relying on virtual care to interact with their health provider. We investigated the reason for consulting with virtually with their provider. And in here, we are comparing two data points. We have June 2020 and February 2021. So the three main reasons that made up the top of the list are, first of all, virtual visit was the only available option, or it was offered by my regular health provider as an alternative to in-person consultation, or virtual care was appropriate to the recent health concern I had. And besides these reasons, so we have other reasons that pertain to, let's say, the classic benefits of virtual care, time savings, convenience, etc. Similarly, we also investigated the reason for consulting in person with health provider. And as you have noticed in the previous slides, in the middle of the pandemic, we had a big chunk of visits that were in person. And the main reasons, let's say the three main reasons reported by Canadians for having their visit in person were, first of all, virtual care is not appropriate to the recent health concern I had, or overall quality of in-person visit is better than virtual visits. So quality was an issue for some Canadians, and virtual care does not meet my needs. Now, moving to outcome of virtual care visit. The results suggested that during the pandemic, the majority of the virtual visits had led to, let's say, predominantly a prescription renewal, 34%, and a new prescription, 32%. Beyond COVID-19, 45% of Canadians, and here I'm looking at the graph on the left, 45% of Canadians reported that they will continue to use virtual care when COVID-19 is tamed or resolved. And they said it's gonna be, they will be using it for prescription renewal, especially for prescription renewal. And I'm looking at the chart on the right, 70% for prescription renewal, or for follow-up of a health problem, 56%. Now, the key takeaway from this part of the presentation is that Canadians did rely on virtual health technologies to seek out care during the pandemic. Now, the question is, who benefited from this surge in consumer adoption during the pandemic? And this leads us to talk about digital health equity. But before we dive into the analysis of virtual, let's say, digital health equity, I would like to prime you with the definition of equity in virtual care. And this definition was proposed by the Digital Health Equity Task Team at Health Canada. And equity in virtual care is the provision of remote health services using any form of communication or information technology to facilitate or maximize the quality of patient care by joining patients and or members of their circle of care in a manner that ensures an absence of avoidable or remediable differences among groups of people based on digital or social determinants of health. Now, that being said, let's first take a look at age and sex together. And for that, we created a combined variable that we call age-adjusted sex. And for this, we will be looking at pre-COVID and during COVID situations. But first of all, I have to mention the main data sources for this analysis are the 2019 and the 2020 Canadian Digital Health Survey, which were commissioned by Canada Health Infoway. And then for access, what we collected 5 digital health services: eView PHI, personal health information, eMental health, virtual video, e-booking, remote patient monitoring, RPM, and we lumped all these 5 in one single variable that we call access to at least one electronically enabled health services, which is represented on this chart by the purple bar and highlighted in green. Now, before COVID-19, what we observed was young women and men aged less than 25 years. They were more likely to access digital health services relative to adult men and women. During COVID-19, there's been a decline, first of all, a decline for youth, and then an increase for adult men and adult women. And then for adult men, we have a proportion of 46%, and for adult women, we have a proportion of 53%. But let me tell you that this increase is mostly driven by access to PHI and then virtual video. We also looked at the virtual care modalities by this variable that we created, age-adjusted sex. And then what we notice is adult men and women, they were more likely to rely on telephone, whereas young women and men, they consumed more video conferencing and secured messaging. Now, for Indigenous peoples, we looked at access before COVID-19 and during COVID-19. And since we are interested in fighting this disparities, so we have a comparison group that we have on the right, non-Indigenous Canadians, and on the left, sorry, we have Indigenous peoples. So before COVID-19, we saw some let's say, disparities in terms of access to PHI, 28% for Indigenous peoples versus 33% for non-Indigenous Canadians. And then in e-booking with a doctor, 27% versus 38%. But with COVID-19, first of all, we observed that there was an increase in access to services for Indigenous peoples. And second of all, the discrepancies or the disparities that we observed before COVID, they seem to fade away, especially for access to PHI, 29%, and e-booking services, 31%. Now, for Black African Canadian descent, we looked at access for only during COVID period because we only collected one data point. And then for that, we have another comparison group, which we have on the right. And for this time, it is white or Caucasian Canadian. And on the left, you have Black and African Canadian descent. So one thing to observe is that Black Canadians were twice more likely to use e-mental health services or technologies and RPM compared to white Canadians. When we moved to the modality of virtual visits, we didn't see material disparities. For example, if you look at on the left, for video conferencing, we have 17% for Black, and for white we have 14% on the right, and then it's a difference of only 3 percentage points. Now, for the remaining slides of this section of the presentation, we try to get a sense of how some social determinants of health impact access to digital health services. And starting with age, we noticed that Gen Z and millennials, they were more likely to access digital health services relative to the other age categories. And then for geographic area, Canadians living in urban centers, they were more likely to access digital health services compared to Canadians living in rural areas. And again, Canadians in rural areas are falling behind in terms of accessing electronically enabled health services. And we are during COVID-19. This is for COVID-19. And lastly, for household income level, what we observe is high-income Canadians were 7 percentage points more likely to access digital health services relative to low income. And there seems to be a positive association between income level, let's say household income level, and access to digital health services. So I will stop there and I will pass it over to my colleague, Bobby, who will be talking about the benefits of virtual care. Over to you, Bobby.
Great. Thank you, Waldo. So if we go back to Waldo's initial analysis, he talked about the prevalence and the usage of virtual care. So next slide, please. I can now speak about some modeling that we did that looked at first financial costs and then some other benefits that we can derive as well from this utilization. So this first slide here outlines what we think are the financial benefits associated with virtual care. And we've got 2 graphs. One is video and messaging only on the left, and the one on the right has phone as well. And the idea here is that we're modeling benefits based on the fact that virtual visits, by definition, are done from a person's home, so they don't need to travel to see a care provider. And that has implications for transportation, distance traveled, not having to take time off work, not having to arrange for care for dependents. all of those things, which can be modeled. So you can see here that total financial cost avoidance based on the volume of virtual care that we saw in 2020 is quite large. We're talking about 2.2 billion for video conferencing and messaging. Add all the phone consultations, and there's over 5 billion in financial costs avoidance attributable to patients. So if we can move to the next slide. Right here, we can also say, okay, well, if the travel needed was avoided, people no longer have to go in person to see their physician or other care provider. Well, we can model the distance travel avoided, and you can see there 283 million roughly in travel avoided through video conferencing and secure messaging solutions. Close to 800 million kilometers if we add phone consultations there. And as well, if we apply an average number of time saved per visit. So again, we ask patients how much time on average does it take you to go see your care provider and come back, and that whole process there. We can say about 32 million hours were saved overall, 87 million if you factor in phone. Next slide, please. So the other component to this, and I'll just step back for a little bit just to explain the different definitions that we use. So up to now, we've spoken about virtual care and referring mostly to consultations done at home with a care provider in lieu of an in-person kind of primary care routine visit. For years, Infoway has invested in telehealth, and telehealth has a pretty well-established history in this country. The Ontario Telemedicine Network grew to be one of the biggest, if not the biggest, network in the world for telehealth. And you know, the telehealth programs focused on delivering care to rural and remote communities by connecting large academic health centers that are located in urban centers with those rural communities, and providing those links to enable video consultations between those remote communities and those specialty centers. And those consultations focused on consultations with specialists for things like mental health consultations, you know, cardiology specialists, etc. And if we model those activities as well, we can say that 3 million hours were saved in terms of patient time for those patients to travel, and over 400 million kilometers in travel avoided. Putting all that together, if we go to the next slide, we can see that if we call virtual care the combination of those personal visits done from home and the existing telehealth program, we can see that about 90 million hours were saved for patients in aggregate, and about 6.1 billion in avoided financial costs. And one thing I wanted to point out here is that if you look at the relative savings from the two programs, we've got about 3 million hours saved from telehealth, 87 million hours from primary care. And that's just because the volume of primary care consultations is so much higher than those specialty consultations with rural and remote patients. However, those patients typically have to travel much longer distances. So when you look at the kilometers saved, it's a pretty big number, 400 million saved by rural and remote patients. and big number, 5.6 billion saved by patients who did not have to travel to see their care provider. Next slide, please. So having done all this and looking at the financial side of things, that's not the only angle we wanted to look at. So there's another opportunity to look at the CO2 emission savings associated with reducing the need for in-person travel. So if we take the same number of virtual visits and apply a general factor converting kilometers traveled to CO2 emissions, then we can see that 212,000 metric tons of CO2 were avoided overall. And when you factor in phone and virtual consultations, 75,000 just for the video and messaging components. And all of those, as you can imagine, much higher than levels that we've seen prior to 2020 when this activity was much less. Moving to the next slide. We also looked at the telehealth consultations. And again, we looked at the kilometers in travel avoided and the resultant CO2 savings from avoiding that travel. Again, putting all of that together on the next slide, you can see that 286,000 approximately metric tons of CO2 were avoided. What does that mean? Well, it's a pretty significant number. It's the equivalent of taking over 60,000 passenger vehicles off the road for 1 year, or it's enough to power more than 50,000 homes for 1 year, or planting close to 5 million trees and measuring the carbon sequestration over 10 years. So it is a significant impact on the environment. So moving on, we wanted to see if that angle and that benefit, the environmental side, resonates with Canadians. So we first asked, are Canadians aware that healthcare itself and healthcare delivery contributes to greenhouse gas emissions? And 37% said yes. However, 83% responded that they are concerned about climate change. And about half are aware that virtual care can reduce healthcare's greenhouse gas emissions. Perhaps most importantly, about 2/3 would be more likely to choose virtual care when they knew that virtual care can reduce greenhouse gas emissions. So the takeaway here is that I think it's important to increase awareness of the link between healthcare delivery, greenhouse gas emissions, and also that virtual care is an opportunity to reduce those emissions. Next slide, please. All right, so I will pass it over to Ellie now to speak to you about digital health literacy. Thank you.
Thanks, Bobby. So we're gonna switch gears and talk about digital health literacy for a bit. We used some of the data that we collected from a national survey, specifically the 2020 Canadian Digital Health Survey. And we looked at the digital health literacy of Canadian adults and conducted some related analysis. So next slide, please, Waldo. Just a little bit of a background. We all know that digital health literacy is becoming more and more important as our interactions with the healthcare system is becoming more virtual. The COVID-19 pandemic certainly accelerated this virtualization of healthcare. So with that in mind, the goal of this study is to assess the digital health literacy of Canadians, and I say adults, but really they're 16 and above, using a standardized tool called eHealth. And we want to investigate how factors such as age, gender, socioeconomic status interact with this digital health literacy measurement. And hopefully this will deepen our understanding of how various factors influence and impact our understanding of digital health literacy. And then this can lay some foundations for future targeted national campaigns. Next slide, please. I sort of spoke to this in terms of the problem definition, but you can imagine with the proliferation of virtual care, of various digital health services and tools, there will be impacting existing social disadvantages and health disparities, right? So some folks might be better equipped to use these tools and others might not. And also past research has shown that over 40% of US and Canadian adults have low basic literacy levels. This suggests that there are segments of the population who will inadvertently struggle with the concept of digital health literacy, finding and using information, health-related information online. I want to provide a basic definition of digital health literacy. Here we're we're talking about skills needed to search, select, judge, transform, communicate, and use online health information. And why study this? Because it can be used as a public health intervention. Understanding how different populations use digital health information online can help us to equip them with better tools and information as they interact with the healthcare system. All right, next slide, please. This slide is meant to show you that there are a variety of ways to measure digital health literacy out there. There are self-reported tools, self-ratings, and then there are performance-based tools. And the eHealth tool that we used is just one of many ways you can measure digital health literacy. It's a self-rated tool. And next slide, please. We chose to use this because it's easier to administer on an online survey because they're reporting their experience themselves. So making the data collection easier, but also that it's been widely used. There's tons of publications on this in various countries, and it's been validated and used repeatedly. So we feel pretty confident about using this. And next slide, please. Going into the methodology, so our data source, as I spoke before, it's an online survey collected from 6,002 individuals between August 13th and 31st of 2020, so during the COVID pandemic time. It's an online survey, and the data was weighted using the 2016 census reference variables. The dependent variable that we're looking at is the eHealth score, and I'll go into a bit more detail on the next slide, but it is an 8-item measure of digital health literacy, and it's developed to measure the consumer's combined knowledge, comfort, and perceived skills at finding, evaluating, and applying electronic health information to health problems. So just remember that this is the individual's perception of a variety of things. And we conducted descriptive analysis and univariate exploratory analysis. We also did a multivariate regression to look at the factors that influence digital health literacy. All right, next slide, please. So this is the score. There are 8 questions you can see on the right. That is the scale on the right there. They have an option to select on these 8 questions: strongly agree, agree, undecided, disagree, and strongly disagree. The bar charts, the histogram on the bottom is the distribution of the scores. So for each of the questions, depending on their answer, it's given a score of 1 to 5, 1 being strongly disagree, 5 being strongly agree. And then we add up these scores. So the minimum score anyone can receive is 8, and the maximum is 40. And the average in our population sample is about 27. Next slide, please. The screen is a bit frozen on my side. I'm not sure if it's the same. Oh, there we go. It's appearing slowly. So the first variable we looked at is looking at digital health literacy in relation to age categories. So the mean and the weighted mean and the median was highest among those between the ages of 16 to 34, which is not surprising. So it just means that younger individuals tend to be or perceive themselves to be more digital health literate. There is a significant difference between the scores between the age groups, and within group of comparisons also yielded significant results. Next slide, please. The next variable we looked at is gender identity. And by gender identity, we have 4 categories, which are men, women, other, and then there's a category of prefer not to say. Now, this one is a bit interesting. We did find a statistically significant difference in the mean digital health literacy scores between all these groups. The other category had the highest average and median. We're not really sure why that is. And the prefer not to say group had the lowest weighted mean and median. Next slide, please. We also looked at education levels. So for education levels, we had 4 distinct groups. They are no degree, diploma, or other credentials. There is a group of people with bachelor's degree. More than bachelor's degree just means those who have a graduate degree or are working with a professional degree. And then there is a group of unknown. Prefer not to say. I combined these groups because they had such low sample sizes. The median and weighted mean was highest among those with more than a bachelor's education. Essentially, what we're saying is that those with more years of education tend to have better or a higher digital health literacy score. And that is statistically significant. And also comparing any of these groups within each other, they're also statistically significant. Next slide, please. We also look at household income, and also not surprisingly, groups with higher income had a higher median and weighted mean of digital health literacy score. Again, the association between household income and digital health literacy score is statistically significant, and within group comparisons also was significant. So if you look at the chart on the slide, those making more than 100K a year had the highest weighted mean and median in terms of the digital health literacy score. And the prefer not to say group had the lowest. Next slide, please. The next variable we looked at is insurance coverage, and this is meant to get a sense of whether they had to pay out of pocket for some of these services. So those with private insurance coverage, and by that we mean private insurance on top of your provincial coverage, had the highest weighted mean and median for digital health literacy scores. This is probably closely tied with their employment status as well. There is a statistical significance, there's a significant association between insurance coverage and digital health literacy score. And again, within group comparisons was significant among all the groups except between those with no coverage and those with public coverage only. Next slide, please. The next variable we'll look at is use of digital health services. So on the survey, we asked Canadians whether you have used a slew of digital health services. There were 15 different ones, including, for example, e-booking, accessing your personal health information online, telephone consultation with a provider, video consultation with a provider, e-mental health services. So there are 15 of them, and we created this variable on in terms of 4 categories. So if you said yes to none of those services, then you had a score of 0, 1 to 3 services, 4 to 6 services, and those who have used the most amount of services are categorized in that group, 7 to 15. Those who used more than 7 digital health services had the highest weighted mean and median for digital health literacy score, which is not surprising. So we're not talking about causation, just association here. So those who have used more digital health services had higher digital health literacy score, which makes sense. And this association between these 2 variables is statistically significant, and within group comparison also yielded significant results, except for those who used none and those who used 1 to 3 services. All right, next slide, please. So we wanted to look at how these variables in combination affect and predict digital health literacy scores. So we did a multiple regression analysis where the independent variable is the one listed there on the slide. So the result says that the independent variables did statistically significantly predict the dependent variable, which is the digital health literacy score. However, the proportion of variance that can be explained by the group of independent variables included weren't very high. So it explained about 10% of the variability that we see in our population, which just means that there's a bunch of other things that also impact and predict digital health literacy score that we haven't considered or taken into account in our model. Next slide, please. So in conclusion, digital health literacy has significant association with a number of demographic characteristics. We know that they are important when considering someone's digital health literacy level. And gender, age, insurance coverage, education, income, and digital health service use did significantly predict digital health literacy, however, did not explain a whole lot in terms of its variability. And as we continue to collect more information this year in our national survey, we will be considering to refine and include more information in our model so that we can, get a better understanding of what exactly are the combination of factors that predict digital health literacy among Canadians. Next slide. Those are the citations. And I think over to Sukrita.
Thanks, Ellie. That was great. And great work, everyone. Lots of great content and great insights into the proliferation of virtual care throughout the pandemic, but also areas for us to think about with respect to digital health equity, the environment, and digital health literacy as we think about sustaining and supporting the future of virtual care. So I am eager to get to the questions we have, and just a reminder that you can use the Q&A function on your Zoom toolbar at the bottom there to get in your questions. Maybe I'll start with a question for Ellie, since you just finished talking about digital health literacy. A question about looking at the eHeals paper that you referenced, and that they found the statistical difference between males and females. And the question is, wondering if this might point to one of the limitations of the tool, and that it may not have been designed with the range of population represented. Do you have any insights into that tool?
So I did some background research on this tool. Although the literature base in Canada isn't very strong, it's being adopted and refined and adapted in a number of countries. So I did feel pretty confident about at least the tool was meant to measure what it was developed to measure. I think going back to the gender issue, I do think there are gender differences in our understanding and how we perceive online health information. I think it is important to take into account gender as a variable and build that into our model. So looking at digital health literacy campaigns from both angles, from, maybe I don't think we should think about gender as a binary thing. Maybe it should be on a spectrum, but doing gender-based analysis to make sure that we are covering digital health literacy as a concept for all the individuals out there, no matter how you identify as in terms of your gender. I hope that answers the question.
Thank you. Thank you, Ellie. That's I think that was insightful. Maybe we'll work backwards, and then a question for Bobby. That was a really great analysis on the environmental impact, or just like a preliminary look at the environmental impact in healthcare interactions. Do you have any insights on other jurisdictions or countries that are the relationship between environmental impacts and healthcare?
Yeah, thank you for the question. Sorry, I'm trying to focus intently on what you're saying because there's some stuttering going on in the transmission. But I believe that what you're asking is, are there other countries that are looking at the environmental impact? And the answer is yes. Some of the research that I've seen is from the UK. And the NHS is working on a tool that they can provide both patients and, I believe, providers to help them evaluate the environmental impact of a particular visit. So it's kind of like a calculator where you can go in and say, okay, well, my appointment is 30 kilometers away. What is my mode of transportation? Am I going to ride my bike? Am I going to drive? Am I going to take public transit? And then depending on that, it would let you know how much environmental impact that visit would have. And then roll it up to a more macro type indicator, for a particular type of clinic, or maybe for a hospital providing different types of services. But essentially, it's the same idea of converting avoided travel into emissions, with the added feature of, having the opportunity to change the mode of travel to get a more accurate predictor. But the idea is to support both on the demand side, on the patient side, give patients another way to think about how to obtain care, and also give healthcare providers a lens into deciding whether or not to offer virtual care to their patients.
Great, that's very interesting. Thank you for sharing that. And we'll go to a question for Waldo. This is in relation to the equity analysis that you presented, and whether you got a sense of why the differences we were seeing with respect to access. So the question is, for example, was it that providers are making assumptions about who's using virtual technologies, young versus old? The fact that people who are older tend to have more comorbidities, so would go in for an in-person visit, but with COVID, they didn't want to take the risk or so went online. Or was similar, or providers in rural areas, maybe the ones not providing the access, and that isn't the patients who lack access to virtual. So really looking for your insights on some of the differences in access that we're seeing.
Thank you for this question. I think one thing that I would like to say is when we look at access to virtual care services during COVID-19, because we have to take into consideration the COVID-19 context. So adult or old people, they were more likely to contract the virus. So probably that was the reason, probably the reason why they were more likely to use virtual care technology. So they don't want to expose themselves to the virus by going to doctor's office or working clinic. That's probably one reason. Now, when in terms of rural area, first of all, recall that when COVID-19, when telehealth, which is another version of virtual care, telehealth in its inception was created to provide access to rural Canadians. Now, with the COVID-19, where you have people in urban centers tend to be more impacted by COVID-19. So this is probably, wouldn't test whether there was an association with that. But one thing that could explain that, it probably urban centers or people living in urban centers, they were more likely to contract the virus, so they tend to use virtual care technologies at a higher rate relative to rural Canadians. Does that answer your question?
That's great. That is very helpful. And maybe we'll wrap up with a question for everyone, and we'll sort of do like a rapid fire thing. So the question is more broad. It's what, given all the different areas that you're working in, what are some other measurement activities that we need to increase our understanding of the impacts of virtual care? So maybe I'll start with Bobby maybe, and then just go, because I see him first on my screen, and then go to Waldo and Ellie.
Sure thing. And one thing that comes to mind is just I mentioned looking at the demand side and the supply side. In the UK example, same thing here. We've looked at the patient side of things and asking Canadians about their use and desire to use virtual care. We need to look at the provider side as well, and see about the ability to deliver virtual care by clinicians, the appropriateness, what are particular types of situations or scenarios where virtual care would be most useful and would make the most sense, and get an understanding of the subtleties, because we know that virtual care is not something that is meant to replace in-person care altogether. There are scenarios where it's appropriate and others where it isn't. So really understanding that, I think would be a priority, in my opinion.
Great. Then maybe we'll move to Waldo. Do you have any thoughts on what future research or measurement we need to increase our understanding of the impact of virtual care? Oh, Waldo, you're on
Sorry.
mute.
Yeah, sorry. I just noticed that. I think getting more information on the social determinant of care, because what I've noticed in the literature is we collect a lot of information on the social and determinant, the determinants of healthcare, so we concentrate more on access. I think we need to collect information on quality, how virtual care is impacting quality. We have the information and access. We know, we have evidence that virtual care is making a difference in terms of accessing care. Those who don't have access to care can have access to it through virtual care. Now, what is the impact of virtual care on quality of care? Is virtual care, does virtual care allow us to get better quality? We know from the survey, some people reported the problem of quality of care, but we need to have this information. We need to create evidence so we can better educate these people that are a bit reluctant to use virtual care because they see a problem of quality.
That's great. I agree with you. And Ellie, do you have anything to add to these two great suggestions we've heard on?
We've heard a lot of great suggestions already. Thanks for the question. I agree completely with what has been said by Bobby and Waldo, and I think as Canada matures in this area, so I feel like we've kind of just been thrown into this virtualization of care because of the pandemic, and now we're trying to understand how this all works, what kind of information we need to collect. But I think as we mature, we're gonna, for example, understanding how virtual care can impact our healthcare system as a whole. So whether it be on health equity, whether it be on the patient satisfaction, whether it be on the provider side, provider efficiency, tapping into administrative records, looking at exactly how virtual care is being delivered, how it's being used by Canadians. And from that, I think we can then generate some really good evidence in terms of appropriateness of care, usage patterns, and how we can move forward with virtual care in Canada as the pandemic hopefully ends soon and into the future, once we get back to our normal lives.
I agree. Thanks, Ellie. Those are great suggestions, and I agree with all three of you. Lots of work ahead for us in terms of evaluation and measurement in the space of evaluation and measurement. I've also got a slide up here informing you of some of the work that we at InfoWay have been working on with respect to generating evidence in virtual care. So feel free to visit some of these reports and evaluation activities. And then, Walter, if you go to the next slide, we've also got a link there to InfoWay Insights, which is a dynamic access to some of our data from the survey of Canadians, and some of which you've seen referenced in the presentations you saw earlier. I think that's the time that we have for today. Thank you everyone for joining, and I'm looking forward to connecting with all of you again virtually on a future webinar. Thanks again for taking the time. Bye, everyone.